Hey guys! So I wanted to go through mucosal lesions today, and this would include ulceration, any blistering or any colored lesions in the mucosa. Now, I personally don't like this topic because it's really confusing and lots of things overlap, and you'll probably hear it in my voice because some of it doesn't make sense. So I'd highly recommend that you download the poster in the link below, because there are lots of like diagrams and like random mnemonics that you can use just to remember things, and it'll also be good to just like see that in a nice like high definition while I'm running through this so that it makes sense and you can see. Also, there's some things that I'm not going to go through, like this, the granulomatous disorders, because I don't know too much about it. I would just add into a differential diagnosis, oh, it could be this, it could be that, but not go into it. So, ulceration is the first one. So an ulcer is, a breach in the integrity of the overlying epithelium, and it could be caused by several things. So there's like a mnemonic here that gives you like reasons for ulcers. So we have like systemic reasons, malignancy, local, which is like trauma, and then aphthase, so recurrent aphthous stomatitis, and then some drugs. Okay, so we have trauma, is there sharp tooth, denture clasp, anything. But of course, remember, if it's persistent for more than like 3 weeks, you want to do that urgent referral because it could be malignant. Then you have the drug-induced, so this includes like nicorandil and phenytoin. And then after that is like the recurrent aphthous stomatitis. Now, minor, major, repetiform, we know that. I think the best way to diagnose is like clinically. They'll always ask about like size and how like the crop size and the healing and the scarring. So minors will be less than 10 millimeters is like the max. You'll find they come up in like 1 to 7. I think it's like yellow with a red rim around it. And then healing will be within 2 weeks and there won't be any scarring. Major ones will be greater than 10 millimeters. You'll typically find them in the soft palate or the oropharynx. They tend to mention that. So every time soft palate ulcer comes up, you're like, oh, okay, it could be major ulcer. They come up in 1 to 3, like 1 to 3 at a time, and they'll take about 4 weeks to heal, so it's a lot longer, and they will scar. Herpetiform ones, really, really, really tiny little ulcers, pinpoint size. They come up in like groups of like 20 to more. They'll coalesce and they'll be extremely painful, and you'll typically find them in the palate and the gingiva. Now, reasons for recurrent aphthous stomatitis is the stress. You can get smoking cessation, so RAS typically hits the non-smokers actually. And then any anemic, so anemia, so any blood deficiencies, malabsorption, which will, like for example, malabsorption will lead to, like, it could be caused by celiac, and it could cause like a malabsorption of B12, and then you end up with like a macrocytic anemia, I'm pretty sure. And then the two important things about RAS is that you need to make sure that you've ruled out 2 diseases, so Behçet's and HIV. So if they ask you like, oh, you know what else could be causing these oral ulcerations, is these 2 diseases. So for Behçet's, you would want to make sure that you look at the eyes, genitals, skin, and joints for any lesions that could suggest that maybe they have Behçet's. And I think that's typically I think you need a Turkish background, increased prevalence there. And then in terms of HIV, you'll have like an older male, he's like older than 40, he's male, and you can't find a reason for his ulceration, so you want to check his CD4 count and make sure that he doesn't have HIV. Then what I also put it is like radiotherapy and chemotherapy, so those cause mucositis, and then ulcerative lichen planus, so you'll get erosions with yellow fibrinous sloughing on top. Now moving on to infections, lots of these infections cause ulcers, but just to group it up, bacterial, we've talked about this, so syphilis can cause these snail track ulcers. And then you'll also get ulceration in TB. And then with viral ones we have, so I always like to refer back to other posters. So we've already talked about this, and we've done like HHV1, and we said that 2 is for genitals, and then 3 is zoster, and then 4 is Epstein-Barr virus, and then 8 was Kaposi's, right? So in viral, so primary herpetic gingival so HHV1. So this is the first time it hits you. Typically kids, you'll get lots of ulceration in the mouth, but it would heal in 2 to 3 weeks. Typically you give acyclovir in the beginning, but then afterwards, again, you can't do it, it's not as effective. And it's extremely infectious. Then you have herpes labialis, which is a secondary, like a reactivation of HHV1. And you'll get the crusting and you'll get ulceration like on the outside of the lip. And you can also and like the nose. I've had a patient that presented with an ulcer on the nose. It's interesting. Herpes zoster, so shingles. This is the latent virus in your trigeminal ganglion that can then be reactivated, usually with stress, immunosuppression, or sunlight, and it will reactivate within that dermatome, so usually maxillary or mandibular, and it will usually affect that side, so like it won't cross the midline, and you'll get like ulceration as well. HIV will present with oral lesions, but there's a whole poster on that, we'll go on that later. And then fungal, you get thrush, Candida leukoplakia, antibiotics, store mouth. Again, that was in the white lesion poster. Moving on, I think this is the biggest thing when it comes to mucosal lesions, blisters. So trying to make that differentiation between pemphigus vulgaris, mucous membrane pemphigoid, and erythema multiforme. Actually, erythema multiforme is a bit different. But it's mostly that one, vulgaris and pemphigoid. So I'm going to refer to them as vulgaris, and no, fine, pemphigus and pemphigoid. I find that really confusing and I don't want to mess it up. Okay, we'll start with pemphigus. So, I think the best way to just remember what's going on is pemphigus is more superficial, and then pemphigoid is deeper. Okay, so the S's together, the D's together, and we'll start with pemphigus. So this is the superficial one, and it's superficial and it's more serious. Okay, that's how I remember it. So this is the one where you get blistering within the epithelium. And so what it is that you have these desmosomes. These desmosomes are connecting your cells within your epithelium together. So what happens is that you have like an autoimmune, these are all autoimmune diseases, so you'll have an autoimmune reaction. Your own cells will start attacking the desmosomes, or the proteins connecting the desmosomes together, and they'll detach, and you'll end up with detachment within the epithelium. Okay, so above the basal cell and below the keratin, you'll get detachment within, and then you'll get blistering in the middle. Look at the diagram, it helps a lot. So the desmosomes that they're attacking, so the proteins they're attacking are DG1 and 3, which are on the desmosomes. And you have autoantibodies that are attacking them. So then you'll get intraepithelial, so blisters within the epithelium. That causes ulcerations, and that's why when you touch it, it will suddenly blister, and then that constant touching will keep causing more and more blisters, and it will make the mouth really raw and prone to infection because it's just like an open wound. So that's why that one's more serious. So pemphigus is superficial and it's more serious. Okay? Tests to check if it's pemphigus or pemphigoid, because both of them cause blistering. You would use 2 things. So on a biopsy, you will see what they call acantholysis. So lysis is splitting, so you will see splitting within the cells in the epithelium. And then there's the Nikolsky sign. So this is a test where you touch the mucosa, you move it like laterally, and if that causes blistering, so if you're like, you remove and then it will cause a blister, it's a positive Nikolsky sign. So yeah, have a look at the diagram, it helps. Immunofluorescence is another test that you can do, and you'll see on the diagram there's like little dots. So if you were to take a biopsy and you were to send it off for immunofluorescence, you would find IgG highlighted within the epithelium, because your IgG, so an autoantibody, is attacking a protein within the epithelium, so naturally you would find little highlights within the epithelium. Okay, these are important things to just differentiate between pemphigoid. So that's vulgaris. Also, you can get skin and eye lesions, but that's just extra. Mucous membrane pemphigoid. So this is the deeper one. So pemphigoid is deeper, and it's not as deep as the other one. So what it is you have now, it's a different cell that's being attacked. It's again an autoimmune disease, but it's a different cell. So now, have a look at the diagram. You have your epithelium, and then underneath your epithelium is a layer of basal cells, and then is your connective tissue. In mucous membrane pemphigoid, you're attacking cells a bit deeper than the epithelium, and they are the proteins on your hemidesmosomes. So hemidesmosomes are keeping your basement membrane, your basal cells, your basal cells to your basement membrane. Sorry about that. So hemidesmosomes are what's attaching your epithelium to the basement membrane and the rest of the connective tissue. So these hemidesmosomes have proteins on them, and your autoantibodies come and they attack those proteins, and then what happens is that you get a split between the entire epithelium and then the rest of the tissue. Alright? So, we have proteins on the hemidesmosomes. This causes subepithelial ulceration. Okay, so I'm very tempted to going back and compare, trying not to. I'll do it right after this. So the thickness of the epithelium, that your epithelium stays intact and you don't get any blistering within, it's underneath the epithelium. So that's why your Nikolsky sign can be positive, can be negative, but it won't be as true positive as the other one, because when you rub this time, you still have a whole thickness of epithelium that's protecting. So it might not blister as fast. It'll probably take a few hours for it to blister and rupture. So that's what differentiates in terms of Nikolsky sign. And then in terms of immunofluorescence, if you took a fresh biopsy of this one, sent it off for immunofluorescence, so this is going to highlight again your autoantibodies. You're going to find IgG, your autoantibodies, attacking cells. But all these cells are in one line because they're all attacking the hemidesmosomes, which are just right under the basal cells. And they're right there, tuck, 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 and so you're going to see like a really neon line of autoantibodies. Right, so quick comparison. Vulgaris, superficial, more serious. You're getting splitting within the epithelium, so really quick blisters when you scrape it. And in terms of immunofluorescence, you'll find scattered autoantibodies within the epithelium. In terms of pemphigoid, you have, so pemphigoid is deeper, and it's along the basement membrane. You get splitting of the entire epithelium from the rest of the tissue, so you'll get a blistering between here, but it's quite protected because you still have that epithelium on top. And then in terms of immunofluorescence, you'll find just a line of highlighted autoantibodies. Wow, that was really hard. Okay, erythema multiforme. this one affects the mouth. You also get skin lesions, you get eyes and genitals will also be involved. In terms of skin lesions, the most common one to mention is the target lesions. So you get these red spots with like targets around them. You get so crusted, swollen lips, they'll split really easily and they'll be bleeding. And then in terms of in the mouth, you get lots of ulceration, eruptions, sloughing, and then onset can be, so what they can say is that, oh, patients had an infection of herpes and then they suddenly started getting blistering in the mouth. So herpes infection can instigate erythema multiforme, or certain drugs can, so sulfonamides and barbiturates. You might hear the term Stevens-Johnson syndrome. It's just a very, very severe version of erythema multiforme. There's some other autoimmune, so linear IgA. I think this one is the immunofluorescence is highlighting IgA instead of IgG. There's bullous pemphigoid, which is a more common version of mucous membrane pemphigoid, but it affects the skin rather than the mouth. Dermatitis herpetiformis, no idea. Epidermolysis bullosa. This one is very similar to pemphigoid. Okay? Epidermolysis bullosa, so epiderm, skin, lysis, splitting, it's the same concept. So you have autoantibodies attacking your basal cells. So that's causing splitting of your skin. So you're splitting the epithelium from the rest of your connective tissue. Now in this one, I guess, fun facts, attacks collagen 7, which is a protein that you will find on the hemidesmosomes. So it will go and attack that, and then it causes subepithelial blisters. So pemphigus, the one that happens superficially, causes intraepithelial blisters, and then pemphigoid and epidermolysis bullosa causes subepithelial, because it's deeper, so it's subepithelial blisters. Then you can get hemorrhagic blistering, and these are blood blisters, so angina bullosa hemorrhagica, it's a fancy name. For blood blisters, you'll find them in the hard palate and the soft palate. And it's really important that you rule out autoimmune diseases and bleeding disorders. So I'm going to skip this, but essentially what this is like sarcoidosis, Crohn's. They can cause mucosal ulceration. So we know Crohn's is like that cobblestone appearance, mucosal tags and deep ulcers. And it's really close, like it presents very close to orofacial granulomatosis. So you have to, every time you're presented with that cobblestone mucosal tags, you want to rule out Crohn's. So you check for rectal bleeding and other things. Pigmented lesions. So this is the last one that I'm going to go through. So if you see like a colored spot in the mouth, you can blame it on racial pigmentation depending on the ethnicity of the patient. Or any foods or drugs. So betel nut, we said, stains the mouth, chlorhexidine, any antibiotics can, tannins, tobacco. Apparently Addison's can cause pigmented lesions, but I think the most typical one that we will see are like single, if you see like a single lesion, it's like grayish black, it's probably an amalgam tattoo. Take a radiograph, you'll be able to find out. Kaposi sarcoma, so this was the purple lesion, so it's a malignant purple lesion that you can find in patients who have HIV. So if you see a purple lesion, make sure you rule out HIV, take a test, and otherwise it could be melanoma. So this is a benign cancer, I think. Melanoma sounds like it. Found in the palate and the gingiva. You can get nevi, so just like brown spots in the palate. And then melanotic macules, so lips and the gingiva. These are also benign. And they'll be, again, colored brownish purple lesions in the mouth. All of these ones, I would say, again, it's just you're putting it in your differential diagnosis. There's not much explanation in the book, and to be honest, they're very, very similar to each other. The only one that is a problem is like that Kaposi sarcoma. But if the patient has malignant melanoma, that's an issue because that's cancerous as well. So I guess you would want to check those biopsy for any dysplasia. Purpura, so bleeding in the mucosa. This one's really interesting because, like, okay, I'm going to jump back a tiny bit. These vesicular bullous lesions, they can present very similar to like mucoceles. So if you're given, oh, you see a bump in the mouth, it's like blue. Or it's blister in the mouth that hasn't ruptured yet. You should add, like if it's in any area of the minor salivary gland, I would add like mucocele, and then I'd go into blistering lesions. So you have to mix and match other lesions as well. In terms of this one, I found it really interesting that hemangiomas and telangiectasia can be like present in the mouth, but when you press it, so hemangiomas you'll find in like cyst lesions and in like cysts and tumors of the jaw. But if you press those, they'll blanch, whereas with purpura, so any blood accumulating within the mucosa, they're not going to blanch. Cool distinguishing factor. So purpura could be caused by trauma, could be this one, angina bullosa hemorrhagica, so that's a blood blister. And then any like thrombocytopenia, so low platelet counts, could be caused by drugs, I'm assuming antiplatelets. Could be autoimmune or leukemia or HIV could be the cause of thrombocytopenia. And amyloidosis. Up here is just how to come up with a diagnosis and distinguishing lichen planus, lichen node reaction, and lupus erythematosus. Have a look at that on your own time. I am running out of time. So I hope you found that helpful. Just up here in the corner, I have something about hematinics and blood count. So if you ever suspect anemia, you want to do, and it's like, what investigations would you do? So you do a full blood count and hematinics. And if, let's say, a patient is low on B12, could be because they have pernicious anemia or poor diet. If they have low ferritin, they could have bleeding from their GI tract or GU tract, and they could potentially have celiac. Earlier I think I guessed B12, but I was wrong, so ferritin. And then folate could be due to alcoholism or poor diet as well. That's all what it says up here. It's not in the poster. Cool, I hope you enjoyed that. I hope it helped, and hopefully I will do HIV and tongue lesions next. Thanks for watching.